So hello, everyone. I'm Ryan Mackman, and I'm a business consultant with Salient Healthcare. I want to welcome you to today's webinar. It's titled The ACO Risk Transition Triangle, a Success Strategy for ACOs with Downside Risk. Now, a few items of note before we get started. All attendees have joined the webinar today in listen-only mode, so please don't worry about muting your microphone. I also want to inform everyone that this webinar is being recorded, so you will have the opportunity to re-watch the session and even share it with some of your colleagues. ACO Exhibit Hall is going to email you a link of the recording and the slides following this presentation. Finally, during the webinar, you'll be able to submit questions to the other presenters and me using your attendee control panel at any time, and then we'll answer as many of those as possible during the Q&A session that we have towards the end. These questions are also being recorded, so even if we're unable to get to yours during our allotted time, we're going to make sure that we follow up and answer it via email. Now, this presentation is a collaboration between ACO Exhibit Hall and Salient Healthcare. Presenting with me this afternoon, Dr. John Schmitt, the Executive Vice President for ACOExhibitHall.com, and we also have Dr. Craigan Gray, Salient's Chief Medical Officer. The ACO Risk Transition Triangle is actually the brainchild of several conversations between the three of us because we all frequently meet at various conferences throughout the year. At the core of this presentation is that Pathways to Success is continuing to push ACOs towards taking on greater risk, and the key to success in this iteration of CMS's Medicare ACO program is balancing what Dr. Schmitt refers to as the risk transition triangle. Dr. Schmitt?
Hey, thanks, Ryan. And welcome everyone to this webinar about a new ACO risk transition strategy. As you may know, the backstory to this quote from Seema Verma, which you're looking at now, the administrator of CMS, is aggressively pushing Medicare ACOs into risk arrangements because basically the growing spend for Medicare beneficiaries' healthcare is not sustainable. So in that regard, another CMS initiative is also taking form in 2020 called the direct contracting model. Under that model, under that model creates 3 new CMS voluntary risk sharing options. And you can find more out about those options by searching the CMS direct contracting model, just Googling it. The bottom line is that CMS is trying to encourage even more medical providers to engage in risk-sharing arrangements over the next 5 years. Okay, now the purpose of this webinar is not so much to focus on the why of Medicare ACO risk initiatives, but rather the how to prepare to succeed if you're part of an ACO or a direct contracting model with downside risk. So that leads me to explain the slide you're looking at, which we'll call the ACO risk transition triangle. You see, ACOs that are inexperienced in downside risk find themselves in a conundrum, right? How do they succeed in a complicated business with no strategy for success? And unless they can present such a plan to the member providers they need in their organizations, well, they encounter a reaction that's frequently referred to as risk adverse. So to address this conundrum, we're presenting the ACO growth model slide you're seeing now. It is a high-level strategic plan with 3 components: membership attribution, risk management, and performance results. And the arrows suggest the flow among the 3 components: membership attribution, risk management, and performance results. So as we wrap up the presentation, I'll go on to explain how success is achieved by moving from one component to the other. So at this point, I'm going to turn it back to Ryan to introduce, the first leg of the risk triangle, membership attribution. Ryan.
All righty, thank you, Dr. Schmitt. Now, the reason that we placed attribution at the starting line is because having control of your own population is going to build the basis for everything that comes after. If you're consistently losing beneficiaries due to plurality of care or just because your providers aren't seeing them, then it becomes extremely difficult to calculate performance because you introduce a lot of volatility to your data. An ACO has to focus on keeping beneficiaries continuously assigned. Your churn rate is what dictates the volatility of those assigned beneficiaries. A low churn rate enables ACOs to have a lower variability, and then lower variability then allows for more accurate prediction of performance. Finally, more accurate prediction of performance then lends itself to greater mitigation of risk. Continuous attribution really helps with lowering costs, it improves quality metric compliance, and it helps to accurately code for risk. Beneficiaries that are continuously attributed have significantly lower costs than those that aren't because they're getting the right care at the right time. It's about population management, and you can't manage a population that you don't see. Dr. Gray?
Yes, and good morning. Thank you. You know, that idea about not being able to manage what you can't see is really important. And as we discuss attribution methodology, it's important to look at the different types of attribution methodologies that are available, because these are the tools for your success. Now, there are actually two different attribution methodologies that ACOs can select from as you go through each year. First, there's prospective, and then there's prospective with retrospective reconciliation. The one you choose is arguably dependent upon how experienced you are at running the ACO and how carefully you manage or control the churn rate that was previously mentioned. That's very important, as well as a few other strategies that fill in behind it. So let's discuss plurality as a topic first, as it affects this attribution idea. And we'll do that before we dive into the two different attribution methodologies. Now, the bottom of the graph on your screen refers to plurality. You can see that, and you see that the two attribution methodologies don't touch each other. They both intersect with plurality, as you can see. Now, this is purposeful because plurality is the logic that identifies which providers saw or cared for the beneficiaries in your ACO during the most recent performance period. Now, this is not simply based on the number of visits, but also includes dollars spent with each provider. In this case, the annual wellness visit, which you'll hear about again and again, helps with attribution because it reimburses at a higher rate than the usual E&M codes. Furthermore, and perhaps even more importantly, the annual wellness visit is clinically beneficial for the patient. It's a great time to reduce clinical risk and improve outcomes. This is an important step in managing the risk triangle and improving the triple aim of reducing cost, improving outcomes, and improving patient satisfaction. So let's take a look at the two attribution methodologies. First, we'll consider prospective attribution methodology. And this is where CMS provides a list of beneficiaries that are attributed to your ACO prior to the performance year. Your job is to properly manage those beneficiaries' health. CMS uses plurality logic to determine beneficiary attribution annually. One of the easiest ways to augment beneficiary retention is to ensure that everyone in your prospective attribution list sees their primary care provider for an annual wellness visit. See, there you've heard it again. For beneficiaries with chronic conditions, they should potentially see their primary care physician 4 times a year based upon clinical need. And for healthy beneficiaries, we would recommend that they visit their PCP potentially twice a year based upon clinical need. Now, if you don't see these beneficiaries and they visit other providers outside your ACO, that's when you run the risk of having plurality issues. And of course, you begin to see and you start to see the churn rate increase. When these prospective attribution, when using prospective attribution, you run the risk of poor financial and quality performance because you're kind of unsure of where your beneficiaries are receiving care. This route, this type of attribution is best if you're really skilled at managing churn. And if you have experience with Medicare Advantage, because they often use very similar methodology. In other words, providers, doctors, must really engage with their patients in providing good care. Now, next, let's take a look at prospective attribution with retrospective reconciliation. Now, this is the most common attribution methodology. With this option, you receive your list of beneficiaries at the beginning of the year, and then CMS does monthly adjustments based upon quarterly attribution file. You can both lose and gain patients on a quarterly basis. This type of methodology is best used by potentially less experienced organizations who are unsure that their churn rates or they're in markets unsure of their churn rates, or if they're in markets with Medicare Advantage penetration. And anyway, in other words, you want to use this so you can continue growth as needed. Keep in mind, every expert was once a beginner. Now, also note that good, solid, high-quality care is the foundation of success. Now, let's take a further look at population attribution. Now that you've decided which attribution methodology is ascribed to, then it's time to consider the measures that ensure you're managing your churn rate. This first important measure is about continuous attribution. Now, here we have shown the Salient dashboard widget that displays your percentage of continuous attribution. And in fact, it's one of the most important measures you can look at. It's part of Salient's attribution overview dashboard. Now, this is what's going to ensure that your doctors are seeing their patients quarter over quarter, year over year, and establishing continuity of care and retaining them. Now, this makes good clinical sense as well as good administrative sense. Now, if you're seeing over 70% of your population, you can be reasonably confident that you'll be able to decrease their expenditures, such as unnecessary hospitalizations or emergency room utilizations. Now, on the other hand, in today's environment, with the onslaught of the COVID-19 pandemic, it may be important that you make sure that these patients get to the emergency room appropriately, are carefully managed in the hospital, and that the transition visit back home or potentially to another facility is managed carefully as part of your overview of your population. Additionally, you want to proactively manage your chronic patients so that they remain stable or improve. And this is particularly important in this time of COVID-19. This is also a very good measure to increase the other quality metrics and compliance metrics that are needed to drive your success. Now, in the example we see here, Q1 of 215X as a denominator. Now we see Q2 and Q3 have continuous attribution above the 70% threshold. Not bad, keep it up. However, by Q4 2015 here, we see that continuous attribution drops to just over 65%. Red flag, this corresponds to a churn rate of over 35%. This change is an opportunity to dig deeper to find out why. So let's take a look at some of the data that will help solve this problem. And Ryan, guide us through the next steps.
All right, thank you, Dr. Gray. So you've had a chance to gauge your percent continuously attributed population. And just like Dr. Gray said, you're going to want to take a look at your percent seen on a quarterly basis. The percent seen on a quarterly basis helps you to retain your attribution. CMS states that 70% of the Medicare population has one or more chronic conditions. So if each practice has 70% of its population with one or more chronic conditions, then that means 70% of the population has to be seen at least once per quarter. And that's going to help you manage churn and then improve the quality of care for patients with chronic conditions. This widget that you're currently looking at actually breaks down the percent of beneficiaries you've seen by each quarter. Using the Salient Healthcare dashboards, you can actually filter this by practice or by provider for accountability of performance. Now, this ACO is seeing patients at a rate of 50 to 60%, which is why it's shaded in yellow. These yellow highlights, along with red or green, are designed to provide directive insight as to the direction that you're trending. So green would be in a desired, red would be in an undesired direction, and yellow is considered to be neutral. Now, the last component of attribution that I want to talk about is annual wellness visit completion. And that's because AWVs have a significant impact on attribution. If you're bringing your beneficiaries in for an annual wellness visit, you can build that physician-patient relationship, and that's going to lower your churn. And you can schedule those patients for follow-up visits, which that's really going to bolster attribution, because each of those beneficiaries will now have been guaranteed to see your PCPs at least twice. This widget you're looking at shows your percent of AWV completion year to date. And ideally, you also want this to be at or above 70% by the end of the year for the exact same reason that I mentioned on the last slide. If you can get your AWV percentage up to 70%, you've got a much better chance that your percent seen on a quarterly basis will also be at or above 70%. And that gives you a better chance to push your percent continuously attributed up over 70%. So now you're starting to see how the different pieces fit together. Now, before I hand this back to Dr. Gray, I want to make one thing clear. Getting your attribution locked down is paramount to mitigating financial risk, which is ultimately what this presentation is about. If you can't meet the expectations provided regarding attribution, you're not going to be ready to move down the glide path to take on more risk. Dr. Gray?
Sure. Now, once we master the data driving attribution, but keep in mind that that's an ongoing and continuous process, then you can feel confident that you're managing your population well enough to start to grow your market share. That's important for your organization as well as for your community. You want to be smart about this, though. Be sure to do diligence. Do you know the providers, the doctors that are willing to work with you? Those who have been successful with population health management? Those who share your vision for the community? These are all very important elements as you consider adding additional people, physicians, and providers to your ACO. Remember, it's better to add small practices who are willing to work with you than larger ones who aren't. Most of the time, you'll want quality over quantity. Of course, you always keep in the back of your mind the 5,000 beneficiary threshold that's required to participate with an ACO anyway, but you know that. One additional insight for attribution for ACOs is the idea of retrospective attribution. This is the retrospective attribution methodology that's about assignables. The assignable population are beneficiaries that have seen at least one of your ACO providers, but they're not attributed to your ACO. Now, it's possible to engage these patients quickly, starting with the annual wellness visit. There we go again. You see how important that is in terms of its overall success administratively and clinically? And this clinically solid method then begins to grow your ACO organically. Now, Salient has a proprietary likelihood logic that will help you determine the level of effort required to convert assignables into attributed beneficiaries. And when you manage your attribution, your attributed population, you manage your financial risk. When you're ready to manage your financial risk, well, that's what my friend John Schmitt's going to talk about next.
Thanks, Dr. Gray. So yeah, we're going to take a little bit of a deeper dive into the subject of risk management. Risk management's a science. It's been around a long time. Over the years, I've studied it with respect to various areas of healthcare, malpractice, and other areas where there's loss exposures. And even many universities offer graduate degrees that deal with educating students about the probability and management of loss occurrences that result from different types of risk exposures. For our purposes today, I want to simply reduce the science to 5 generic steps that apply to ACOs dealing with their loss exposures from medical care delivered to that attributed population we've been talking about. Okay, so the 5 steps you see on this slide encompass various strategies to minimize the loss exposure of ACOs taking on downside risk. Now, it's important to understand that risk cannot be eliminated, but it can be proactively minimized. So many of the risk management tactics taken by ACOs have been reported, as you probably have seen in a plethora of articles and webinars. Things like risk assessment, physician engagement, care management, and reinsurance are just a few of the management strategies you may have read about or even employed yourself. What I've found by being involved with the management of several risk-bearing ACOs and interacting with many ACO execs is that there's often not a comprehensive strategy, however, that explains how all these action steps work together. In other words, there's often a lot of risk management related programs or activities underway, but no overall plan to proactively manage the various risks that are associated with ACO financial loss exposures. Okay, that said, let's walk through these 5 steps and I'll provide an example of how each strategy can be implemented. Since we're limited in time, I need to move through them fairly quickly, but please realize there's a need to take a deep organizational dive into each one of these. So one final note before we start with step 1. The 5 steps are not sequential, but they're really simultaneous in nature. So collectively, they constitute a risk management strategy with kind of 5 moving interactive parts. Okay, let's take a look at step 1. So step 1 is risk identification, and that involves Medicare ACO loss exposures and limits. So the identification of loss exposures and limits is an important first step. This slide particularly outlines the half-dozen options currently open to ACOs within CMS Pathways to Success program. As you'll note, as the ACO types move from basic to enhanced tracks, the loss sharing limits at the 3rd column increase. And in turn, the shared savings rates, that's the 4th column, also tend to increase. And CMS caps the loss exposures, that's the 5th column, as kind of a percentage of the ACO's total cost benchmark. So the risk management challenge here is to specifically identify and then quantify the loss exposure with respect to the projected cost of medical care provided to the ACO's attributed population. The risk exposures of the direct contracting models mentioned earlier have not been released yet by CMS. Now, it's important for ACOs to understand that risk identification, it's a fluid process. It changes constantly since medical costs, for the member beneficiaries continue to increase daily. Dynamic loss exposures are not impossible to identify, but like Dr. Gray mentioned earlier, they require good financial analytic programs with continuous oversight. Okay, that said, let's go to step 2. Step 2 is risk avoidance. And then in this instance, physician member risk culture change involved. So as you look at this slide, it's understandable that most physicians who have not previously involved in downside risk organizations are likely risk adverse. The inherent problem for ACOs is how to achieve physician engagement in a risk adverse culture. The answer is going to be found in the physician membership of the participating practices. So this slide depicts a bell curve of physician member risk readiness. At the 2 ends of the curve, there are what we could call positive physician champions and negative physician detractors. They generally constitute a small minority of the overall physician membership. The majority of the organization's physicians are either going to be somewhat positive or somewhat negative, and the slide depicts them as evenly distributed along the curve. However, in reality, the curve will likely be skewed one direction or the other. In any event, a risk culture change involves using the physician champions for risk readiness to influence other physicians to become early adopters of the proposed risk plan, i.e. CMS's basic or enhanced track. Physicians tend to listen to physicians more than to non-physician executives, just the way it is. So the early majority who are leaning positive but not committed, they can be influenced by the early adopters. And once the early majority begin to get on board with the new culture, they get the attention of the late majority who are leaning toward the negative side. Now, this late majority, since the culture shift is happening, they don't want to be outsiders or left behind. So it'll take time to move through the curve, but the culture change will become increasingly more apparent in meetings and as physicians just converse among themselves. So the final group, the laggards, will be very slow to come around or even resist the change and become detractors. If that's the case, in time, the detractors may be asked to just leave the ACO because of their non-compliance with new risk management directives like best practices. So finally, the slide depicts several ways to achieve physician engagement in this new risk culture. For example, the champions and early adopters may be placed in influential positions like being on the governing board and holding key positions like the chief medical officer and regional medical directors. The culture change will begin to influence operational meeting agendas, conference calls, and compensation incentive plans. So this step is so important that I want to add that this is not a hypothetical concept. It works. I've seen this change take place in multiple ACOs I've worked with over the years. It does require patience and a positive attitude on the part of the C-suite to find the right champions and then early adopters, and then let those physicians move through the curve to effect the change needed. Okay, let's look at step 3. Step 3 of the 5 steps is risk prevention. And this is an example of an action plan. So now we're in the domain of care management. This slide depicts one of many, many action plans to prevent unnecessary losses and reduce risk exposures. So we all know that the care continuum is a pathway, right, for patients moving through the processes of their medical treatment. So this slide is just one example action plan that a multi-hospital ACO might develop to manage patient transfers. So there are 4 key areas that have bulleted details describing the introduction of a centralized transfer center. So they explain the concept, the ROI, the estimated volume of patients affected, certain key operational elements, and then some potential barriers to implementation. We don't really have time to go through the example in detail, but you'll be sent a copy of these slides along with the recording of the webinar, as was mentioned earlier. Just remember, this is one of the many, many action plans needed to prevent or minimize unnecessary financial losses. Okay, let's go to step 4. So step 4 is risk reduction by readiness assessments. So there are going to be 2 slides involved in this step. Both of them are going to deal with the subject of how to reduce risk by developing and implementing risk assessments. So this first slide is a product of much input from risk managers, actuaries, and reinsurance consultants. It depicts the 8 categories that experts in downside risk look for when assessing readiness within an ACO. For example, do ACO governing board members, which usually include the physician leaders of the ACO, and their executive teams, do they have experience in risk or at least a positive attitude in downside risk options? If they come across as risk adverse, as we discussed earlier, they're really not ready to assume risk responsibilities, and the organizational culture will be negatively influenced by their actions and communications. I think the other criteria are pretty self-explanatory. The next slide is going to offer an example of a risk reduction assessment tool that would need to be prepared to address each of the criteria in this slide. So let's take a look at that. So this would be this is a very short one, but this would actually be multiple pages in length. But as you'll note, the assessment tool in this example looks at 4 areas of ACO financial risk management. Again, I don't have the time to go into each area, so I will just comment on the first line item, medical service expense management capabilities. You see, the fully capitated, full risk ACOs I've worked with track the organization's MSC on a daily basis. The 5 most common MSC categories will include hospital expense, physician expenditures, ancillary service expenses, drug medication spend, and and maybe an all other expense category. And you should know that actuarial firms have much more detailed MSC cost breakouts, which they use when estimating and tracking an ACO's medical service expense. One final comment on this slide. Categorical items that are assessed as development required or have limited capabilities, those are the ones that need specific action plans to bring them into the green in place status. Those action plans will include specific steps, kind of what we saw earlier, specific steps needed to improve the categories and the timeframes to complete the associated step. Timeframe is very important. I should also underscore the fact that these risk assessments, they should be accomplished by knowledgeable and objective risk management specialists. So for example, our exhibitor hall partners like Salient would be a good resource to help in that assessment process. Okay, let's go to the next two slides on risk transfer, and I'll wrap up my section on risk management. Okay, step 5, risk transfer funding options. As you know, taking on downside risk involves a potential for financial loss. We all know that. The bad news is if the ACO does not employ the risk management strategies like the ones I just mentioned to minimize loss exposures, it's going to likely incur devastating financial losses. The good news is that there are several options available to help meet the reserve requirements associated with various levels of financial risk. So in this slide, some of the options like joint ventures, shared savings retention, private equity investment, all these involve kind of internal organizational decisions. On the other hand, lines of credit and surety bonds involve outside financial institutions that offer loans or financial guarantees. The ACO's financial manager will need to assess the loss exposure amounts and present the governing board with the cost and benefits of the various options. One final note here. If lines of credit or surety bonds appear feasible to the ACO, the financial manager will want to prepare specs and then shop for the best offer available. There's just a lot of market competition for new business among lending agencies and surety bond guarantors. Okay, let's look at the last risk management slide. Okay, step 5, risk transfer, aggregation, stop loss. This slide kind of offers an example of the risk transfer option we call aggregate stop loss. Basically, under this arrangement, the ACO transfers some of its financial loss exposure to another entity called a reinsurer. The reinsurer works with the ACO to determine the ACO's financial exposure or liability based on the size of the ACO's membership, its contractual liability, and the amount of projected loss that it can reasonably fund internally. The outcome of the assessment and negotiation results in a stop loss policy that transfers some, not all, of the ACO's projected loss to the insurer in return for a premium. In this example, the financial liability of an ACO is calculated based on its Medicare membership of 10,000 beneficiaries. The performance benchmark is $10,500 per member per year. The loss sharing is limited or capped at $8.4 million. And in this example, the actual expenditure comes in higher than the benchmark at the end of the year at $11,214 per member per year. So since the ACO's loss rate is capped, the ACO's liability to CMS is $2,142,000. The aggregate stop loss policy covers $1,197,000 of that loss, and the ACO's liability share is $945,000. I know I went through this example fairly quickly and deserves much more analysis and discussion. But in the interest of time, I'm going to pass the presentation back to Ryan to wrap up the third leg of the ACO risk triangle, performance results. Ryan?
Thanks, Dr. Schmitt. And the very last piece of the ACO risk triangle is performance results. Now, a performer is someone who's making incremental movement towards their goal over time. They compete against themselves, not someone who's just considered above a particular average, right? We're too used to thinking in terms of what I like to call baseball statistics, where you're thinking, if this guy hits this many home runs, well, then he's a performer. ACO data analytics doesn't exactly work that way. Now, What I'm showing here is our ACO scorecard in the Salient Healthcare dashboards. You get 8 widgets that cover several different important key performance indicators. So think of this as your ACO's report card. Now, let's say you have a son or a daughter in school and you want to see them do better each quarter or each semester. ACOs work a lot in the same way. If a practice has an ER utilization of 900 per 1,000, but last year they were at 1,200, then you should consider them a performer. They're improving. There's a lot of ACOs who would say, oh, well, that's a non-performer because everyone else in my ACO is around 500. Well, if all of your other practices are around 500 and they all either stayed there or they got slightly worse from one performance year to the next, then they're not performing. It's the practice with the higher ER per 1,000 that's making an impact for you. And that's because they're the ones who are improving. So flipping this analogy on its head, if you have a practice that had an ER utilization of 150 per 1,000 last year, and they're at 300 this year, they may still be at the lowest rate among your practices, but they actually doubled in ER utilization. So you'd want to watch to see if that trend continues. This practice would appear to actually be declining in performance. And that's why this Salient ACO scorecard looks at percent change and relative size of the practice. You want to look at each practice against themselves between one time frame and another.
Okay, let's talk about how all of this comes together. So the ACO growth risk transition triangle works this way. So the bottom line of the triangle in terms of an ACO success in the world of downside risk, success all depends on how quickly the ACO can effectively move around or transition the 3 sides of the triangle. In other words, the ACO starts out with an accurate membership attribution using the methodologies described by Ryan and Dr. Gray. It must then manage the financial risk associated with the medical care for the attributed population by effectively using a risk management program like the 5 risk management steps I discussed. If the risks are managed properly, then the cost, quality, and other performance results will be achieved at a successful level, demonstrating the ACO's successful performance. So now the arrows you see inside the risk transition triangle suggest movement from one leg of the triangle to another. Again, they're not sequential, but simultaneous. However, as the ACO successfully manages the ACO's inherent risk of its attributed membership, good performance results occur. As the old saying goes, success breeds success, right? So with good documented performance underway, a successful ACO is in a position to grow by taking on a larger number of attributed population, and then the rest of the triangle process proceeds at a higher level. So the speed with which the ACOs move around inside the triangle reflect the faster successful ACO can grow. If you could look at the strategic plans of the most successful risk-bearing ACOs, you see that their growth plans are very ambitious indeed. And I think at this point, I turn it back to Dr. Gray for some closing comments. Dr. Gray?
Yes, thank you. Thank you very much. You know, we all used to travel a fair amount, and take heart, be of good courage. I think we all will again be able to travel more freely than we currently have been in the last few weeks' time. And every time we go on a trip, we always want to think about what's going on at the flight deck, and hopefully they have a very solid flight plan in place. And we also want to make sure that everything on the pilot's checklist gets proper attention. In fact, running an ACO or mitigating risk is not any different. The robust analysis solution that is critical to the element of success in flying an airplane is just as important in running an ACO. Good data, in fact, is the oxygen of the organization. You know, what gets measured gets improved, so they say. Now, you want to keep up on how your ACO is performing, and this means logging in and regularly sharing data with your ACO members. Now, this is especially important about your board members, because board members are potentially the mentors and cheerleaders for the rest of the membership, for the rest of the physicians within the ACO, to bring them all along, to help them become a contributing part of your ACO community. Now, next, we want to and need to understand that attribution and risk are the first two categories that you want to focus on. If you can do that, you can be very successful. And finally, if you can't do that or have trouble doing that, keep in mind there's always help available. Don't be afraid to ask. Now, Salient offers a very robust data analytics solution that requires no complicated query. It's all point-and-click technology. The KPIs, key performance indicators, promote continuous performance improvement that we've talked about. Tracking data across all payer models and incorporating any variety of data sources all become just an ordinary part of the system. Ryan?
Thanks, Dr. Gray, and I'd be remiss to not say that you can try Salient for free for 45 days using your own data, and I, along with our consulting team, will even put together a custom assessment for you so that you can compare our findings to what you already have for your ACO. Also, all of our contact information is going to be listed on the screen at the very end, so please don't hesitate to reach out. So with that, I'm going to actually open the floor now for a little Q&A. This is going to be turned over to Mr. Garrett Schmitt of ACOexhibithall.com. So please make sure that you mention who your question is for.
Thank you, Ryan, and thank you, gentlemen. Great presentation. We do have some questions that have come in that we wanted to ask, and these will be directed to several of you individual, and these are in no particular order. First question being is for Ryan, is what are the benefits of going prospective versus retrospective for attribution? And doesn't your prospective minimize your risk? And I'm sorry, doesn't prospective minimize your risk?
Got it. Thanks, and thanks for sending that question my way, Garrett. So you know who you're accountable for throughout the entire year with prospective. It makes it easier for initiatives because you can put your investments up front. You know exactly where to direct your investments so that your initiatives can be carried out. On the flip side, with retrospective methodology, you have the ability to grow your network. So if there's a large MA presence in your community and you lose attribution because of that, then you still have the ability to gain attribution and make up for it throughout the year. So, and that's not something you can do when you're on prospective. Another advantage of retrospective attribution is that you can get your assignables list. That's going to help you grow your network even more. It also gives you insight into the spend of the greater community, as well as different utilization patterns. With the last part of the question regarding risk, prospective does minimize risk because you're maintaining long-term care of a set group. However, just because you have a set group doesn't mean that your providers are fully taking care of those patients. The mainstays are on that list, but if a patient decides a few months in, oh, well, I dislike Dr. Smith, so I'm going to go see someone else. Then on paper, it might seem less risky, but it's actually only less risky if your providers do an excellent job taking care of those patients. So the risk lies in the patient-provider relationship, not in the attribution method.
Great. This next question is for Dr. Gray. How do you create a comprehensive scorecard that incorporates both clinical and claims data, and what is the best use of it?
Well, this question begs the answer of making sure that you get the most out of your analytics provider. Push them, in fact, to provide exactly what you ask for. I've always said that quality pulls financial data, pulls financial progress, rather than financial progress pushes quality along. So use your analytical system to answer that question. Specifically, does your analytical system have a scorecard, an individual patient scorecard? Patient's name, obviously, contact information, diagnoses, doctors, procedures, and costs. All of those on a single view will help you get a comprehensive look at that particular individual rather than they being lost in the group. So the important thing here is let your quality data pull your financial information along, and that will lead you to the success that you're looking for.
Great. This next question is for Dr. Schmitt, and actually we had several questions that came in that are very similar. So this hopefully will cover most of those. And the question is, Dr. Schmitt, yesterday NACO sent out a press release concerning COVID-19, saying that as a result of swings in unpredictability and spikes in expensive hospitalizations, 21% of at-risk ACOs said they were very likely going to leave the Medicare ACO program. And essentially almost 80% of them said that they were very concerned. So that in mind, how can ACOs at risk prepare now for the impact of COVID-19 in 2020? Dr. Schmitt, are you mute, perhaps?
Unmute it now.
There we
Okay. So that's a very timely question, obviously, but it's a complicated one to answer. In fact, we could probably do a whole webinar just on the response to that issue of how do ACOs prepare now for COVID-19. Anticipating that question, I've tried to do some research along those lines in the last few days, and here's what I found. So multiple research centers like Harvard's Global Health Institute, excuse me, they're reporting they're in a kind of in a fog because the data they're receiving so far is just not very reliable. For example, they say states are reporting COVID hospitalizations differently, and the federal government is way behind on data tracking. So they just don't have much to work with right now to kind of track what's happening so far in the whole environment. The other thing is that hospitals, ERs, and primary care medical practices are just maxed out, as I think we know, treating incoming COVID patients. As a result, though, expensive elective procedures and non-emergent cases are now kind of on hold, and that translates into higher staffing costs but lower total patient revenues. So hospitals are crying out, for help from the government. And for example, the Mayo Clinic reported in Becker's yesterday it's facing a $900 million shortfall this year. And I suspect other health systems are going to proportionally have similar shortfalls. The federal government, in response, said it has already sent out more than $51 billion in advance payments to hospitals. But it's overall, it's just hard to determine the financial strain of the COVID pandemic on the health system and which way it's going to go. So given that, I mean, what does all this mean to ACOs, right, in the trenches? So I would suggest several things in response. This Friday, the 17th, NACOs is hosting a webinar to discuss policy changes with respect to ACOs and the COVID-19 pandemic. You can find a link on their website. And in the interim, NACO suggests several items. One, beef up your care management program to focus on patient needs and emphasize their prevention, very important issue. Two, I want to note that some of our ACO exhibitors, ACO exhibit hall exhibitors, have developed some new tools like COVID-19 registries. I encourage you to go to the ACO exhibit hall and look through some of those booths, and you'll find those products and offerings. Then NACO says also implement processes for effective care transitions. I think we mentioned that earlier. I think Dr. Gray mentioned that. So transitions that are happening from hospitals to nursing homes and other transitions in the care continuum, be on top of that quickly and efficiently. And then they suggest utilize your IT resources to shift patients to telemedicine. There is some new money coming to help fund COVID-19 telehealth programs. And we'll put some of that information out in the next ACO newsstand. But telehealth is becoming increasingly very, very important for taking care of patients' needs while this pandemic is underway. And then maintain focus on both wellness and chronic care for patients. So NACO suggests try to do these things as far as ACO is concerned. And I think a lot of these recommendations are encompassed really in the 3 legs of the ACO risk triangle that we discussed during the webinar. I would add one more thing to NACO's comments based on our webinar: to stay on top of the ACO's medical service expense data daily. The total cost of care is going to be changing as the treatment of the attributed population changes due to COVID-19. And I think at the end of the year, the total cost of care will determine the savings or loss experience of the ACO. And for the reasons I just mentioned earlier, right now, it's very difficult to answer that question as to which way that's going to turn out. As I said, there's a lot here with the COVID issue. I apologize for this kind of long answer, but I hope it helps. And Dr. Gray or Ryan may want to weigh in with their perspective.
This is C. Gray. Just to emphasize the importance of following up on your chronic care patients. Chronically ill patients with 1 or 2 or 3 or more comorbidities are at higher risk and therefore at more expense. And just track those. Make sure that that we integrate them. Make sure they're getting even their social determinants of location, of food, of basic elements of their life can go forward and not contribute to any degradation of their health process during this time that they don't have close contact with your office or even with their own family members. It just means more vigilance, being what we're trained to be, physicians.
Great. All right, guys. Well, unfortunately, we have several other questions that came through, but we are out of time for today. So just for those of you who did submit questions that we weren't able to get to, we will make sure to answer those via email after the presentation. So so hang tight, and someone will get in touch with you regarding your direct question. As we conclude here, I would like to encourage you all to visit the Salient Healthcare exhibit booth at acoexhibithall.com. And this is what that looks like on your screen. And you can learn more about them and connect with their team. And this is also where at the acoexhibithall.com is where you'll be able to get a recording of today's sessions and the slides for download. And you will find both of those in the reference library, but we'll also be sending you a link after the presentation later on today, so you can have that to share with others as well. And lastly, if you have any specific questions for Dr. Gray or Dr. Schmitt or Mr. Mackman, their contact information is here on the slide, and we'll leave that up for a moment here. So feel free to make a note of that and contact them directly, and they'll be happy to get with you for further discussion. So thank you all for attending today. I know it's a crazy time, and so appreciate you making time in your schedule to be with us. I hope you found it very informative and helpful, and hope you have a great rest of your day. So thank you so much for coming.